So it's with pleasure that we are having this conversation today at the 6th CII Health Summit on an extremely auspicious day. अगर मुहूर्त निकालना होता तो इससे बढ़िया क्या चीज़ होती, that it's the Honorable Prime Minister's 75th birthday. And the topic that we are going to discuss is equally important and speaks to the launch of the Swasth Nari Sashakt Parivar Abhiyan, which is a subject very close to your heart, ma'am. I can see that bright smile, which echoes, it is literally coming from your heart. In your role, starting with what we've heard this morning, as the founder and chairperson, the Alliance for Global Good, Gender Equity and Equality and advisor, Women's Collective Forum. How excited are you with the launch of this initiative?
I think the Prime Minister has spent a better part of his life espousing the need to democratize research. For too many years, we in our country have seen that certain segments of excellence repeatedly have emerged or have sustained because of partnerships that emanated from the capital city. His desire, and I've had the privilege of working with him as an administrator for 10 to 15 years and as a political activist for 22 years. And his insistence always has been that instead of being restricted to only certain organizations, can we look at those who excel on issues of, let's say, health and are possibly doing research or innovation in every geography or every demography of our country? And I think 4 papers today is just the beginning of a partnership with CII with regards to the alliance that I chair or the Women's Collective Forum. It is noteworthy that it is very rare where there is much talk that industry, research, civil society should come together. But today's summit, in fact, is a manifestation of that desire. It is for me a matter of great pride, and it's a humbling experience to sit next to Dr. Guleria because he's had a lifetime of service. I've had the privilege of knowing Dr. Guleria for 2 decades, and the recognition that excellence can only be possible if there's a sustained effort to understand an issue like health, which is not stagnant in the challenges that can erupt from it. Yes, the dominance of the gender quotient in today's summit is something that I'm very happy about because we have to be accepting of the fact that not much money goes in to research for women's health. The fact that we could not only talk about maternal health, which is a national priority, child health, which is a national priority, but also look at other issues of women's health, including non-communicable diseases, is something that gives me a lot of hope for future collaborations and partnerships.
Perfect. As ma'am very rightly pointed out, everybody knows you, doc. So, but we are very, very fortunate at CII that you are leading our public health initiative in addition to your clinical disciplines, which is humongous. One of the points that ma'am made, and that is the gender equality that is there. In the medical world, what is your opinion from whatever we know of clinical research, which she touched upon also? Whenever research is done, the data does not throw up what impact it has on women specifically. So they are all clubbed together, and the percentile of women in clinical research standing out as a data point is fairly neglected. What is your opinion and how can this be corrected?
So I think you're very right that there is a little bit of inequality, if I put it that way, and we need to look at it from multiple factors. There is an inequality as far as healthcare is also concerned, and also as research is concerned. Many years ago, we just did a very simple study where we looked at patients coming to AIIMS New Delhi and looked at their address, where are they coming from, and the gender, are they men or are they women? And the further you were from AIIMS New Delhi, lesser the number of women who are coming for healthcare. That meant that we need to reach out to women in rural India because they get neglected and they will not come for tertiary care, and men will always get the priority. So that is a very strong message that we need to work at a rural level, at a primary level, because women health is more important than I would say health as far as men is concerned, because they are, as is the initiative the Honorable Prime Minister started, very important as far as the whole family is concerned. Women are the foundation of a family, and they build the family and they keep the family together. And if their health is not looked after, then the family health itself suffers. That is one point. The second point is as far as research is concerned. Again, I think here we need to work very hard. We need to look at how we can push, because the outlook that women have in terms of their own problem is something that is difficult for men to be able to really work on as far as health is concerned. And there have been initiatives both by ICMR and others to look at how we can push for getting research more done by women and looking at how we can promote that. But a lot needs to be done, and I think that is an area where we need to work hard on, both in terms of providing healthcare and looking at research which is focused and done by women, looking at the issues that they face and which are actually pretty important in our country. And one of them we discussed today was about anemia. It's a major problem. More than 50% of women are anemic in our country, and yet we don't recognize how important it is and why we need to work on really finding intervention strategies to correct anemia as far as women are concerned.
Absolutely, and perhaps to grow on that, when you look at women's bodies and men's bodies are different physiologically also, and a lot of work has to be done in the menopausal, perimenopausal age groups, and that will only happen if we are able to segregate and find out more about it. And even ischemic heart disease, it presents itself very differently in women against men, and most of the data supports what happens in men. Ma'am, with that, I'd like to turn to you. See, 3.9 billion people in the world are women. So they are 60% of the population is women. And to what Dr. Guleria said, that they are the fulcrum, the platform on which a family grows. As a consumer, one would think that purchasing decisions are fundamentally a woman's prerogative. Societal, ethical, moral that you put out there somehow restrict. So many a time a woman would know what a child needs, what kind of nutrition she needs, but she's not empowered enough to take or make that decision. So what in your mind, given the work that you have done, as community, as people, what is it that can be leveraged to give women that kind of power?
I think that one has to firstly, since you spoke about purchasing power, identify that globally, in only FMCG segments and other commodities which are heavily advertised across all medias, the combined purchasing power of women is close to $48 billion. This does not include capital asset investments or other investments in financial institutions or other instruments which are non-financial immovable assets, including gold. Now, you speak about how can we empower women more. It has been researched globally, domestically, that when more finance is available to women, then close to 40% of their personal finances then go towards the health and education of their child. As the financial competence of a woman increases, so does her investment on issues of health. The challenge is for too long, and I think between the conversation of yours and Dr. Guleria's, is a very underlining reason why this is not being mainstreamed right now. Nobody has articulated consistently that research on an issue of health needs to identify the differentiated impact across genders. There is, let's say, and this is subject to correction, if 30% of the deaths in our country is having an underlying basis of cardiovascular diseases, Is there genuinely a study which today by professionals gets bridged to policymakers to say, okay, if cardiovascular diseases kill 30% people in our country, this is why it's killing women? That basic foundation does not exist. So then there is a societal expectation. Why is nobody talking about it? That's because nobody is researching it. Since nobody is researching it, nobody is informing policymakers. And since no policymaker has had that kind of robust, uh, you know, research or academic publications available to them, they cannot reach a very informed decision and make it a part of a budget line. So this is not only about empowering a woman. This is actually creating a conversation across verticals to say this needs to get done. And we know that the moral imperative is not, unfortunately today, a very, very heavy imperative. For people, the economic imperative possibly makes more sense, creates more value. So let's put an economic number to it. In our country, 425 million women are of the working age. As I have said in my health summit inaugural address, 181 million women have an Ayushman Bharat card. Can we start studying that data while protecting the privacy? Look at the differentiated geographies. As Dr. Guleria says, the further they come from, the lesser the number of women. What does that say? That there is a societal priority to men's health in distant locations. So much so that they would put up all that they have within their family economy to make sure that that supposedly must be the earning member or the member who has access or control of capital assets for that family. Hence, they should come to AIMS. So, it is not sufficient to only empower the female. It is essential to work across all these verticals, and that is why it's a challenge. That this is not a standalone issue, it's an issue that needs collaboration.
I think that's a brilliant point. So it comes to Dr. Guleria, like what ma'am said just now. If you are informed, then you ask the right questions and you take the right decisions. But if you are not informed, what do you do? So if we were to focus on health and health literacy from a policy perspective, ensuring that people have that knowledge of health literacy, and as was in the inaugural address mentioned, that we are at a very sweet spot as far as digitalization is concerned, using artificial intelligence. What do you think at a nascent level, right, we can do to inform people so that at least they know and thereby they get influence to make the right decision, at least about health and nutrition?
So I think two issues. One is informing policymakers, and the other is informing the general public, especially women, of what they need to do for being healthy and why it's important for them to be healthy, not only for themselves but for the whole family. And for that, the first thing is to have robust data. We already have that data. India is becoming digital, and we have a lot of digital data. As ma'am mentioned, Ayushman Bharat itself is a gold mine of data. If we are able to utilize the data, tease out these points as to how does gender health really differ from different regions, from different areas, from urban to rural areas, one will be able to really get an idea as to what are the challenges that one is facing, not only in urban and rural India, but in different parts of India as far as women health is concerned. And then be able to work that out in terms of what can we do to correct the fallacies, or let's say the differentials that are there in terms of providing health at a primary level, where one can be able to look at women's health from the point of view of what are the deficiencies based on the data that we have. Currently, a lot of assumptions are made, and that's why a lot of people feel that this is something that is more what is sort of hearsay evidence rather than actual evidence which is driven by data, and that is already there. I feel that we need to collate data which is possibly in different silos, if I put it that way, which needs to come together. And if we're able to look at it, one will be able to get a lot of data. The data lies within the government sector in different departments. This lies in the private sector, in different hospitals, in different institutions. if we are able to find a common platform where it comes, it has to be anonymous, but it will give us a lot of information in terms of how we can provide some sort of sustainable solution, which is region specific, which is specific to different areas, looking at the challenges that they have there, what is the deficiencies, and I think that is something which is crucial to really help individuals and policymakers to move forward in terms of providing better healthcare, not only for the country but even more specifically for women.
Right. I think that contextualized version, as well as it's like the clarion call for everybody who's collecting data. Kindly collect it in a way in which you can use it, basically.
I also feel that there's a red flag, Doc, that needs to be raised right now, because ma'am spoke about the very impending future of how artificial intelligence is going to affect the healthcare system. How do you look at it from a gender perspective? Artificial intelligence currently, as has been envisaged by leaders in the technology segments, scrapes through every data point on the internet and then builds the algorithm accordingly. In the absence of fundamental data points, as has been articulated by Dr. Guleria, can you imagine what the algorithm is building, and why then those who think that the artificial intelligence ecosystem is the temple of truth, then what happens to women's health? So that is a red flag that needs consideration.
Absolutely. You
Unless your
put
data
it.
is robust and good quality, the algorithm is going to give you false outputs. So what comes in, if
Absolutely.
it's not good, what comes out is going to be even worse.
Absolutely. And with the story of hallucinations, ask the question thrice, you'll get 3 different answers. That also is a challenge that we have to recognize. You brought about a very, very important point, ma'am, and that you said if there is an economic imperative. So we have international data to a certain extent, which says that if you were harness the female cohort, yeah, the economic potential is equivalent to $1 trillion, right, if they were into this. But the caregiving economy to support predominantly the women to be able to come in needs a lot of work. Just now you mentioned at the inaugural address, very rightfully, that at the level of the primary care, to ensure that they have institutional deliveries, they are able to have blood, that requires a humongous amount of cross-sectoral partnership. It's like Noah's Ark pulled up, right? So in a short period of time, would you have any 1 or 2 things you'd like to share with us that would perhaps spur this movement?
I think, as Dr. Guleria said, Ayushman Bharat gives us the landscape to build on. But at the same time, given the history of our medical health system journeys as a country, we recognize already the pain points, the districts, the communities that need urgent care. Apart from the gender quotient, the geographical challenges of our border villages, of our districts at the border, of islands, Andaman Nicobar, Lakshadweep, of areas which are difficult terrains like, let's say, Ladakh, especially in the winter, are these spots where we are healthcare ready. But one, apart from infrastructure, data, quality, research, the fundamental challenge still remains the sheer army of healthcare professionals we need. So while the Prime Minister is dedicated towards building more and more medical colleges, more and more institutions of learning for nursing, the issue is, in a diverse healthcare ecosystem, what are the new skill sets that we need for the newer generation of healthcare professionals? What are the skill sets that the already established healthcare professional ecosystem needs so that they can, let's say, use technology to bridge the gap? The other challenge is that the current existing ecosystem of healthcare professionals is genuinely so burdened by the sheer population that they are serving that if they do not utilize that time for service, then they miss out on a patient. And then it is a balance between their own health, mental and physical, and the need to upskill, because there's only 24 hours in a day. So it is a huge burden that our healthcare professional ecosystem today is carrying. A recent study shows that you are talking about the demographic dividend, the young, but we have a huge amount of population that is getting old. Geriatric care today is not the buzzword. So there are challenges aplenty, but the only solution is more and more partnerships that are not only at the top of the pyramid, but that they resolve to serve the genuine bottom of the pyramid. For if the bottom implodes, God help those at the top.
So my last question, and I know exactly what you said, Doc has got a line of patients outside his OPD, so we will not keep him waiting. The last one, and this, you touched a very raw nerve in my body, and that is something that I've been working for decades, and that is changing the way healthcare is delivered through people, right? Doc, you know the story as much as I do. We've been struggling with this to try and change the way we deliver healthcare by devolving, task shifting, and empowering down the lane. Our ASHA workers, Anganwadi workers, they do a fantastic job. But the true empowerment doesn't happen to be able to address what ma'am is saying. Are there any quick thoughts you would like to share with us as to how we can make this happen? Because it's becoming absolutely critical for that last mile delivery.
I totally agree with you, and I think there are 2 or 3 things that I'd like to say. One is we need to be more inclusive. Task sharing has to be there. I think physicians feel that they are the only ones who can really look after patients, but we should have nurse practitioners. Why can't we train our nurses to be able to help out in terms of areas where there is a deficiency of human resources? Other skill training for, let's say, paramedics, how can we utilize them? I think both the nursing community and the paramedics are underutilized in our country. And they are the huge force which can be used. You mentioned ASHA workers. How can we train them and empower them to be able to provide care at both a rural level, district level? That will make a huge difference. And the second is the emergence of technology. Healthcare is going to change dramatically because of emerging technology. How can we utilize that in remote areas where we have limited human resources? We have now so many wearable devices. We'll be able to monitor patients remotely. We did that during COVID when people were in home isolation. Pulse oximeter, they were able to monitor their oxygen, they were able to monitor themselves. Telemedicine, teleconsultations became so common that people from remote areas could reach out to doctors in specialty centers and get advice from them. How can we upscale that to a level that across the country you can have centers where this can be done? We had e-Sanjeevani, which was one part of that, and that is still there. That you can have consultations from rural India to specialists in big cities and big hospitals. I think there's a huge potential there. So if you look at how we can skill our new generations, how we can look at other paramedic and other staff, I think those are things that we need to do rather than still sort of remaining constrained. And as skill training becomes more and more sort of important, how can we innovate in that?
Absolutely. So thank you ever so much for giving us this time. We could have this conversation and go on forever finding solutions, but you are the implementers and the executors. We all look towards you for a much brighter future. Thank you so much.
Thank you.
And I hope all people tuned in have enjoyed this segment.